I found that I wanted to do some more digging. I wanted to start looking into, okay, well, what do we do and how do we take care of this? All right, so participants are going to learn, these are some of the objectives for today: understanding criteria for eating disorders, understanding how to differentiate different diagnoses, learning about the connection between substance use and eating disorders, some common medical complications, and being able to, I'll give you a little bit of an introduction to the integrated care model that we use, but really more to just into the idea of how to treat patients with these two co-occurring disorders. Okay, so one thing, and I know there's a lot of you guys out there who do treat eating disorders, so some of this is obviously not going to be new to you. In a residential treatment center like ours, we see a lot of patients with serious medical issues. Part of an eating disorder and the criteria for eating disorder is not just behavioral, it's really a medical issue, to the point where eating disorders have become the second most, there's the highest mortality rate, second highest mortality rate out of any other disorder. Eating disorders used to be first, and then opiates took the place of the first place in terms of mortality rate. But one of the things that really caused eating disorders to be in that very top part was the medical complications that come along with it. And so when you think about what happens when you add substances into an eating disorder and some sort of, you're dealing with really intense behaviors on the eating disorder side, intense behaviors on the substance use side, and the two of them together can just become like that fire. What happens is eating disorder behaviors are oftentimes camouflaged. So with substance use, and sometimes it's hard to tease out, okay, is this part of their meth use or is this part of their eating disorder? And what happens is meth and so many other drugs and alcohol become part of the eating disorder behavior. People use the substances in order to have their eating disorder. And a lot of times it's this question of, okay, well, what do we do? How do we treat this? Do we treat this together? Do we have to treat eating disorders first or substance first? And that oftentimes becomes a real big challenge for providers to figure out how to do that. And just overall, the two co-occurring disorders make it so difficult for just the assessment, the treatment. Things are more complicated because you're trying to now manage and look at each disorder, the challenges, the risks that the person is going to be facing with each disorder, and then trying to figure out a treatment program that's going to make sense and how to really help get to what's underneath all of that stuff to move that person forward into some sort of recovery. Okay, so one really, really important report came out at the end of 2020, and it was put together by Deloitte. And what happened was, over the past couple of years, the Strategic Training Initiative for the Prevention of Eating Disorders, it's called STRIPED, which is out of Harvard, collaborated with a very big, a big company, a big organization called the Academy of Eating Disorders, to conduct like a very, very deep study on how eating disorders are affecting just overall, financially, socially, all these types of things. And it was a very important report to have done, because research in the field of eating disorders and really understanding their total impact. I mean, we know what it's like for families, we know what it's like for the person, but to really have something that really puts all this together was incredibly important. And so I'm going to share a little bit with you of some of the things that were found. And there's a lot more to the specifics of this report online too, but here are some of the highlights, and here are some of the important things that were found. So at the top, you see the whole section on prevalence and mortality. So about 28.8 million Americans will have an eating disorder in their lifetime. I think a very shocking number is the one below that, which says that 10,200 deaths per year as a result of eating disorder, which equates to one death every 52 minutes from an eating disorder. When you break that stuff down and you see that number, it's shocking. And I know too, just from doing research, looking at how often we're not even getting sometimes people to clearly report, we're missing people in our research oftentimes. So there's a chance that number could be even higher. I think some of the other very shocking things that came out in this report, which a lot of people who are treating people with eating disorders had started to see and recognize themselves, is that the age range has changed. We see people starting as young as 5 years old, starting, even all the way up to 80 years old. From my experience, I'll give you a little bit of a case study example. When I was a primary therapist here at Montecatini, I started working with a patient who was in her, I think she was about 21 at the time. And she had been struggling with the eating disorder her whole life. She had anorexia nervosa. She'd been in and out of treatment, but in so many ways, primarily like academically, she did very well. She was successful. However, everything else really in her life had fallen apart and she was becoming sicker and sicker. Her parents were very concerned and said, we just don't think she's going to make it. We want to do everything we can. Here, please treat my child. That was a lot for me, because the passion I have, the care, how much treatment means to me and what we're doing means to me. I really knew that this was a complicated case for a lot of reasons. I think what shocked me was when she was 7 years old, she started restricting. And one of the reasons that she cited was she was in a Girl Scout troop. They were doing a field trip type thing to a grocery store. They started looking through labels. They were talking about nutrition. They were talking about good food, bad food, all of these types of things. And that stuck in her mind. And so much so that became her life, reading the labels. This is a bad food. This is a good food. And you mix in that event itself was not everything, but in the family system, she had an alcoholic mother. She had a very dysfunctional family system. And it was like all of these factors just hit at once. And it's hard to believe that even in that young age at 7 years old, she started being very conscious of her body and her weight and how she looked. So we know, especially in those kind of situations, when you think somebody starting treatment so young, and at the time when she was trying to seek treatment, there wasn't eating disorder treatment for anybody that age. So she had to go into a child psychiatric facility, which really didn't help treat her eating disorder. You can see some of the costs of the economy. You can see what it's doing to the cost of hospital systems and things like that. And one of the reasons why I wanted to give you and show you this report was a big part of what we have to do, and you all I'm sure have to do, is we oftentimes really have to fight for insurance coverage for our patients to get treatment. And unfortunately, over time, we had a period where things were good. We were able to get really good insurance coverage. People who weren't able to have access to insurance were able to have access to insurance. But things have changed, and over time, more and more people are getting very restrictive policies. People are having a limitation on days and how many days, or they can't cross state lines. And so much of that is affecting people's ability to recover. And I'll kind of explain a little bit more about that too as we go through it.
Sure. Can I pause you really fast?
Sure.
Can we experience the view?
Okay.
See how it's
like
this. So maybe presentation mode.
All right, hold on. I'm going to try to fix my view here. So I think Now, where's my, sorry about that. Or am I, no, I'm not sharing my screen, am I?
No.
No, we can't see
All
it.
right, let me get that back up.
I think you have to press slideshow mode.
It's always so hard to do this in a, let me see. Okay, now I just have to find everybody to share my screen and then I'll be good to go.
I have a quick question, actually. I'm seeing a lot of emails go in the chat box. I don't want it to drown out any of the questions that are going to come in. What is the plan to send out the slides?
Go ahead.
What did she say?
About all the questions coming into the chat box, there's a lot, so.
Oh, yeah.
No, it's just emails, and everybody seems to want the slides. Will there be a plan? Just, I don't want questions to get lost in the chat box.
Yeah. Yeah, I will send out the PowerPoint to everybody after the presentation, and I have everybody's emails from the Eventbrite registration, so.
Perfect. Thank you.
Yeah.
No, that doesn't work. All right, let's try this again. Okay. Emily, what are you seeing?
Yeah, and now press like start slideshow.
Let me see where you,
This is what I see.
oh, you still, I'm so sorry, you guys. Hold on, we'll get this figured out.
May I offer assistance?
Sure.
All right, so I need you to zoom out. All I'm seeing is like, okay, if you go to the bottom, to the bottom, there's the minus sign. Click that. Yep, there you go.
Okay, let me see how you,
Oh yeah, thank you.
okay, perfect. Okay, now let me advance back to where we were. Okay, here we were. All right, sorry about that. All right, so now I'm going to move on, just go over some of the most common eating disorder diagnoses that we treat, that we see clients coming in with. So I think, anorexia nervosa has been one that is, people really relate or understand, not necessarily relate, but they have seen more people and feel as though they can identify people with eating disorders when they're anorexic. So a lot of times, when you see somebody who's bulimic or has a binge eating disorder, there may not be anything external that indicates that they have an eating disorder. With anorexia, it's often and mostly associated with low body weight, and that's how some people really, in their minds, conceive and conceptualize eating disorders. And what's interesting about anorexia and just this whole field in general, this is a newer field in a lot of ways, and a lot of attention didn't come to eating disorders until, a woman named Karen Carpenter died about, 30 years ago or so. And because of her death and because she came out saying that she died of complications from anorexia nervosa, that put eating disorders on the map a little bit more. But unfortunately, what I was just explaining in the Deloitte report was how the ages have changed. There's a lot of information too on just different ethnicities and men who have eating disorders. So a lot of those things weren't known or treated or researched for a long time. So we know that, and things have changed in diagnosing anorexia as well, but it's really looking at how someone's body weight is affecting their age, they're affecting their age. Is it appropriate metabolism-wise? Where are they developmentally if they're an adolescent? And just overall physical health. So let me give you an example. So when we have patients that come in, a lot of times they'll say, the patients that are anorexic who are in a lower body weight will say that I'm most comfortable at such and such pounds. This is where I've been, this is what's most comfortable for me. Anything over that, I don't feel good about. And so then sometimes, and we, of course, we listen to them, but we also know, and we look at this from a very different system of looking at their nutrition, looking at their medical things, looking at just the behavioral aspects of what that is about, and why they feel so, so certain that they shouldn't go over a certain body weight. But we'll get people to a certain weight or that weight they think they feel comfortable with, and then find that medically they're completely unstable. So it's interesting and it's important in treatment to really recognize that there is a range, and we need to see when is somebody's body going to most effectively work, and at what weight is that, and making sure those people are stable in their weight. So that's one part of really understanding what the disorder and how the criteria is for anorexia, because again, the intense fear of weight gain, which is not always, which most likely is an irrational fear, and goes down to the last point, which there's incredible disturbance in what somebody sees as their body and what they feel they look like. And a lot of times that piece stays with people for a very long time. I often say that, there's a good chance there's going to be some level of distortion with body dysmorphia or just your own perception of your body, possibly for the rest of your life. It's really about finding another way to, and understanding really that, okay, what I'm seeing in the mirror does not necessarily mean that's what I look like, but even more important, that's not what's most important to me. What's most important to me is my values, is my life, is my recovery. Okay, so a few more things that may indicate somebody has anorexia. Sometimes you see dramatic weight loss. There's a lot of people wear a lot of layered clothing. It's very hard to see what they look like. You can see some of these too, the incredible preoccupation with food overall, dieting, feeling fat, just comments about themselves. Also, a big part of an eating disorder is the exercise piece, and this over-exercising and exercising no matter what, even if it's snowing outside, even if somebody is injured, still exercising regardless of that. I had a patient one time who was absolutely 100% determined she had to run. And no matter what, that was not in her exercise plan. And despite she got injured, she had actually been running and fell and broke her ankle. And despite that, she tried to run anyway. And it was just this incredible, she's a very smart girl. Despite that, it didn't even occur to her that, okay, this is not a good idea. This is dangerous. I shouldn't be doing that. For somebody who otherwise, unfortunately now is in recovery, she can look back and say, wow, I can see how my brain just wasn't seeing or understanding or processing what was really going on. There's also, going back to the mortality rate, that it's around 12 times higher from other causes for people that have anorexia. And we'll get a little bit more into some of those medical pieces of what makes that so. But one here saying 60% of those people are experiencing sudden cardiac arrest, organ failure, or suicide. Now, I want to bring to mind, if you think about that, that's a huge number. So if you think about that alone, just for anorexia, what happens when you have somebody who has anorexia who's also drinking? Or what happens when you have somebody who has anorexia who's also snorting coke? Because that helps with reducing hunger, more, just metabolism speeding up. The possible impact and medical emergent situation that person is in is so much higher. So in thinking through all of these things that we're talking about, and looking at these diagnoses, if you consider what it would be like to add in some sort of substance with what we're seeing and reading, it's pretty overwhelming.
We have a question, Sharon.
Sure.
Oh, actually.
Mm-hmm.
The first one is BMI the easiest way of measuring an eating disorder?
That's a really great question. So that was a big part of the previous criteria, was BMI and IBW ideal body weight and a percentage. So that is still some part of the evaluation, but what people are trying to really take into consideration, it's not just BMI, because there may be somebody who is at, say, an 18 BMI, which is not, you know, that can be low, that can be dangerous, but in somebody else that may be their normal body weight. What really has to be evaluated is looking at what their BMI, you know, based on what a registered dietitian has determined is the right BMI or percentage of IBW for them, but making sure too that medically and dietarily they're doing everything they're supposed to be doing, and that BMI is, you know, is stable. So I don't know if that makes a ton of sense. But
We have 3 more questions.
okay.
This is good. How would I notice on an admission day to my detox if a patient sorry, I think the question is, how would I notice if a patient came into my detox and they had a history of eating disorders, but it wasn't mentioned in their notes?
That's another really good question. And that happens a lot. So I think what's important is that knowing, and I'll get to the statistic, but I'll tell you now that it's almost about 50% of people who have a substance use disorder have some sort of an eating disorder, and vice versa. So to assume that there's a good chance that person may have some sort of eating disorder, I think what's important is really evaluating the medical situation and the medical status of that person, which in detox is something that is typically done anyway. Because if you can see that this person is having, you know, a slow heart rate or a very elevated heart rate, or if an EKG is showing some sort of arrhythmia, if you have lab work that is off, that's particularly dangerous, say somebody has a very low potassium. It's hard to necessarily know all that, but I think the better the assessment and evaluation at the beginning, the better off you'll be. But again, one of the difficult things about this is that people who have both oftentimes do not want to give up the other. So a lot of what we see, people that are going into substance use care, going into detox, they don't want to talk about their eating disorder because they plan on, okay, maybe I'll stay sober, but I'm sure gonna, you know, restrict, or I'm gonna keep purging, I'm gonna keep binging. So those types of things do happen. But I think overall, what's most important is really evaluating the medical presentation from the patient overall. And then trying to figure out, once you know that eating disorder has been a part of it, is really trying to incorporate the treatment plan with that knowledge, if that makes sense. So.
Do you want to answer these other questions?
Sure, I'll go ahead.
Like other co-occurring disorders, does substance abuse serve to self-medicate an eating disorder, or does it serve a different function?
It does. It serves to, you know, I think what you'll see is this interchangeable type of use from either an eating disorder and substance use. There's some commonalities between eating disorders and substance use and what they do, because in a way, self-medicating. So if somebody has anorexia and doesn't have a substance use disorder, and even this is the case with bulimia and binge eating disorder, there's oftentimes this feeling of numbness, detachment. So you do get that feeling, like the same type of self-medicating of, this is too intense for me, I can't deal with this. So when I'm using my eating disorder, there's a detachment and a numbness. And oftentimes it's, you know, obviously the same kind of use that those using substances are. It's just a way of avoiding any type of fear, you know, staying in denial. The same kind of thing works with eating disorder behaviors. Okay, is there any?
There's a couple more questions.
Okay.
Are we classifying orthorexia as an eating disorder yet?
That's a good question. Actually, it's not technically a documented disorder. It's being used and being it's being put under a different type of eating disorder that is now in the DSM-5. So when I'll show you that, because I'll get to that slide in a minute, and I can discuss that a little bit more there. Okay, is there anything else?
Yeah, there's a couple more.
Okay.
I have a client who states she has to use cannabis in order to eat or in order to eat,
Mhm.
basically. Is there anything I can do as a nurse to support her? She's having therapeutic intervention from drug services.
That's something that we see a lot of too. So we're getting a lot of people, we're in California, it's not hard to get a card, a medical marijuana card. We have a lot of, that happens where we have people come in. The only way I'm able to eat is because I'm smoking. When we really kind of delve into that and tease that out, okay, maybe that is what, and that's what's real to them, that's what they're experiencing. But I think what's important in the whole scheme of recovery is that it's important to get to what's underneath the restriction in the first place. And that's where the true recovery is going to be. Marijuana is going to really just dull and prevent, in a lot of ways, the ability to do the kind of clinical work and dietary work, everything that is going to help that person be able to get out of that in that rut. And so there's a lot of people that have, there's been some research on this too, because this is becoming such a big issue. But in my opinion, in the way that we work here, it's just one more thing to essentially cloud that channel, cloud that connection to the information, to the work that really needs to be done for somebody to get to the point where they don't have to use marijuana to eat, that they have so many other tools to be able to do that. So, hope that.
Okay, then one more question.
Sure.
I'm a psychotherapist in the UK specializing in dancers of all genres all around the world. I had a career as an elite dancer and understand the dancer's mindset. The UK's National Health Service uses a stick with dancers instead of a carrot when they deprive a dancer from doing a daily class unless they put on weight. This happens even when the BMI is just below normal. For dancers and athletes, the BMI isn't, to my mind, matched reality for a dancer. I would like your thoughts on this.
That's well, I'll give you a little bit of my background. I was a professional dancer for a very long time. That was my focus. I was dancing professionally before I got into the field of therapy. Started when I was 3, went all the way through college and beyond. So I understand that mindset too, and it's interesting how things have evolved and changed. I think again, the BMI can be tricky, and it really comes down to, is my body healthy at the BMI I'm at? And a lot of times what may seem, like a normal BMI according to the chart, doesn't mean that's the right BMI for a person's nutritional needs. So just to give you a little perspective, back in the 50s, the BMI chart changed, and it became, in many ways, it was not helpful, because it says now more people are obese, more people are overweight. This was influenced in part to the diet industry. And so, I do have a resentment against the BMI chart, because what happened was so many people, so many doctors were following that, but in effect, it doesn't necessarily represent a person's health. So I think it is very challenging. If you are in a emotionally and physically good place when you're dancing, and when you are part of a company and you're having those pieces put on you of making sure that you're maintaining that weight, I think it can be tricky, but it's, again, just really evaluating emotional and physical health. So, okay. All right, so here's a few things on bulimia. Oh, I realized and so some of the things that are a hallmark of bulimic behaviors: you have to eat within a discrete amount of time, within a 2-hour period. There's a lack of control during that period, that episode. And then in addition to that, there's a compensatory behavior that comes along, and that is preventing weight gain, whether it's purging, laxatives, exercise, or fasting. The binge eating and the compensatory behaviors occur on average at least once a week for 3 months. And again, the self-evaluation is unduly influenced by body shape and weight. And here's a little bit more. So some of the things you may see, you may see food disappear, you may see wrappers, You may see containers that are missing or gone. And then somebody who's purging, it may be making frequent trips to the bathroom, a lot of those things that you'll notice. It smells of vomit. People are just, they disappear during the meal, after. And a lot of people use fluid and caffeine in order to really stay full, to kind of, keep them from losing energy because they're malnourished. But there's people that are knowing that, okay, I need to cover up. A lot of bulimics will have like a whole plan of how it works and what they do and their process. It's very much like a ritual, as in substance use. Carrying their gum or their mints, doing, they have a ritual that, they're hoping and wanting to make sure that people aren't onto them. And a lot of times you'll see people with, really bad dental issues. We've had folks here who, I had somebody once who was in her late 30s at the time, and she had so many of her teeth had fallen out. So many of her teeth were rotted that had to be pulled out. And so she had so many different implants, and this was at such a young age, and it really was all that acid and what it had done to her teeth was so intense. Something else too that's very common, and not just with bulimics, but with anorexics and binge eaters too, is self-harm. Something we see a lot of here also. Okay, and then a little bit on binge eating disorder. So similar in the sense of the eating disorder, the binge episode has someone eating in a discrete period of time, the same as bulimia. Eating portions that are larger than what most people would eat in a similar amount of time, which can be a little bit confusing. But when you're really working with somebody and a dietitian is working with somebody and getting examples of what they're eating throughout the day, and it's a lot more than what a typical normal plate would look like, that is considered, can be considered binging. And then the feeling of being out of control and that you can't stop eating. And so 3 of these following things need to be there: eating much more rapidly than normal, feeling uncomfortably full, eating large amounts of food when you're not physically hungry, eating alone, or being embarrassed, feeling disgusted, or depressed and very guilty afterwards. So I think what's really important to understand about binge eating disorder is that there's so much now in research that has shown that people with binge eating disorder don't have that same ability to have the satiety that other people have. So let's just say, which is a really hard thing to even categorize now, like a normal eater, which I don't even think that exists. Let's just say a non-disordered eater. So over time, just nutritional values, what's recommended, plate sizes, portion sizes has changed so much, especially in the US. And little by little, we've seen portion sizes which were once way more than what people were eating, say 40, 50 years ago, is now a normal. I think everybody knows that, you go to fast food and there's this larger size, there's, medium and large size quantities that you can get. And so that has been really disruptive and unfortunately blurred this idea of what is a normal portion size for me based on my caloric needs. And a lot of people don't really know that. But then you get somebody who, with binge eating disorder, doesn't feel satiated. They don't feel that sense of physical fullness. That has a lot to do with what's going on in the brain. And that's a real thing. So for instance, with anorexics, they oftentimes don't have the same amount of hunger cues that others do. And that is dulled for many reasons. It can be in part due to circumstances that are going on in the brain, also just long-term malnutrition, but it is something that is not easy on either side to work through. One of the things to do in treatment is really helping people slow down, eat mindfully, and get into an idea of, okay, I'm hungry right now. Let me check in with myself. Let me see what that hunger is. Am I very hungry? Here at Montecatini, we do it by numbers, based on that. And then we also do the same with somebody once they've completed a meal, because oftentimes people feel full very quickly, and sometimes people don't feel full much at all. So those are some important aspects to understanding and treating different eating disorders.
We have a question.
Okay.
This is more on getting authorization for like the clients when they're here.
Mhm.
Given managed care using metrics of BMI, IBW, 75% or greater,
Yeah.
meal completion, more days than not, actively participating in progressing therapy, medical stability, etc. What recommendations can you offer to providers to optimize continued authorization for treatment?
So that's a really good question. With especially a lot of the providers now have changed their criteria. They're going off, different types of things like MCG, Milliman guidelines, different software systems that are essentially determining the right level of care. I recommend doing, what we do here, is always go is refer to APA criteria. APA criteria for eating disorders will be changing. It's actually, they're working on changing the criteria now. The hope is that the new APA criteria will be out in a few months for eating disorders. But it's really referencing APA criteria, which still has some of those numbers in it. But I think what's important is understanding the medical necessity. So even if somebody is at 75% IBW, or they're eating, 100% of their meal plan. But if there's somebody who is still say if they're hypermetabolic, say if they are still in some sort of refeeding, or say they have a lot of abnormal labs, or they're having issues, GI issues, cardiac issues. It's really, I think, important to bring that part into it. But also, what I tell insurance companies is, it's not about just getting to that number, because the reality is that in order to see true weight, true progress, you have to see a trend and also some stability. So you don't want to just say they've reached this goal, they're good, because a lot of times you step them down to a lower level of care, they're moving more, they're not eating the same, and they're going to drop 5-10 pounds in a couple weeks, just simply based on the fact that they're hypermetabolic. I think it's important to really emphasize the need of seeing some stability and trend upward, rather than just a quick, discharge or step down. I know that's not easy, but really making sure that the APA factors are a part of that criteria. Okay, so a few more things. Some of these things we already talked about that are present with binge eating. Some of the things that are similar to what we talked about with bulimia, there may be people, a lot of times there's stealing food or hoarding food. Self-esteem is typically very low. And there's kind of going back to that part of what substances do for patients, binge eating does for patients too, and the fact that they feel a sense of numbness and disconnection. And so many people with substance use disorders that's constant of what they're seeking, is that feeling of being, I don't want to feel, this is too much, it's too painful, I can't deal with it, I need to detach myself. And then some other things here, like you can see about the satiety, and also people creating the whole lifestyle and ritual. Another thing, again, the connection to substance use, rituals, which is something that people with substance use disorders have and create too with their substance use.
Sure, we have another question. An average person who doesn't have an eating disorder but hasn't been eating enough, we generally put them on a calorie controlled diet for a few days. Should we be doing this with someone with an eating disorder? I'm not sure if this person works in the hospital or like a treatment center, but
Can you read that one more time?
Yeah. So an average person who does not have an eating
Okay.
disorder but hasn't been eating enough, they generally put them on a calorie controlled diet for a few days. Should we be doing this with someone that does have an eating disorder?
That's a good question. I think it really depends on the degree of the eating disorder. But this actually came up in a talk I was giving last week to some folks at a hospital system. And with eating disorders, the evaluation, the understanding of what nutritional needs, all of those types of things that they need is so important. And, you know, fortunately, that will be done in a hospital setting. But I think it's important, really important, to take into consideration their eating disorder history and how that affects calories. For instance, if you're saying that, you know, if you see somebody who's not just maybe underweight, because they don't have to be underweight, but somebody who hasn't been eating much at all, and then you put them on this meal plan and they start having symptoms of refeeding syndrome, that can be very dangerous. But I think it's important to really, again, evaluate the medical condition, look at what kinds of caloric needs this person has, and also just to be able to give some sort of guideline and oversight is really important because, again, you know, people with eating disorders often look completely what somebody would consider they would be in a normal or average body size. And so many of those folks fly under the radar. So I hope that answers the question. But again, just understanding the medical complications, possible complications of the eating disorder, and then making sure that the evaluation of caloric needs is going to be followed, especially since when somebody's body is trying to heal, when somebody's body is trying to detox, and if you think, if they don't have the nutrients, or if they've been malnourished and have had just overall inconsistent nutrition, it's going to be very hard to heal and to recover from anything. So, okay. I'm not going to get too much into these, just to mention these two other eating disorders that are part of the DSM-5, and then over here to what is now called ARFID, which oftentimes can be difficult to diagnose in whether it's anorexia or whether it's ARFID. Essentially, there's a lack of interest. People may oftentimes be underweight. And the reason why they're saying they don't want to eat could be because of a texture based on the fact that their senses of the food, whether it's the texture of it, the smell of it, there's something that that really disturbs them in the way that they have a hard time consuming the kind of caloric needs that they have. So let me move on to the next one. And then here to OSFED. So I don't know what that yellow line is. Do you guys see that yellow line? I don't know where that came from. Sorry, but the PowerPoint that we send you guys will not have that yellow line. So I'll take that, make sure that's gone. Anyway, so here with OSFED, so these are some of the other things that fall under this category. And you guys can see that and read that. But orthorexia is another one of those things that really is kind of getting put into this category too. Again, so orthorexia, for those who don't know, is essentially people that are not willing to eat things that aren't organic or raw or whatever it is, but there's a prerequisite on the type of food, the cleanliness in a sense, or the way the food was grown, things like that. And based on those things, they are unwilling to consume foods that aren't in that category. And ultimately, a lot of times people say, well, I don't have anorexia, I'm just orthorexic. But again, it's important to do a really thorough assessment because those two things, you know, somebody may start out with that orthorexia, but then they end up essentially becoming anorexic or even bulimic. So, okay. So I'm just going to go over some of these medical complications quickly. And if I went into each category and talked about what all of this looked like for eating disorder patients, and then add into what it looks like with somebody who has a substance use disorder also, it would be an entire presentation on itself, but of itself. So one of the big things that is very important to evaluate with patients with eating disorders is the cardiac system. And like I mentioned before, that's one of the main reasons why people die with an eating disorder. And it's not uncommon to see people that have electrolyte imbalances, lab abnormalities. Based on those lab abnormalities, the cardiac system cannot function with ongoing malnourishment. the body is essentially shutting down. It doesn't have the calories and the energy to fuel all of these body systems, these organ systems. So the body starts selecting which organ system may not be priority. So oftentimes, women will lose their period. The brain, that's another big area that gets affected, where the frontal lobe stops working, which is really important in judgment, planning, really all those things that you need for recovery. But the body is in this state of fear and shock of, I don't know when I'm going to get my next meal, all the calories I need. And so many different organ systems have to kind of work in this efficiency mode. So the endocrine system, thyroid, people can really do a number on their thyroid. The GI system is one that pretty much can affect and really change sometimes the prognosis of somebody with an eating disorder. So somebody who's been purging, what that does in terms of taking away and stripping all of these little villi, which are in the GI system. And those little fingers of villi are responsible for pulling nutrients. And so when you've been purging, or when you have had, when you've been using laxatives, those things start to disappear. And so understanding when somebody's starting to eat again and eat more consistently, they still may not be getting all the nutrients they need. But on top of that, somebody who's been using laxatives for a long period of time, the GI system basically ceases to function, and it takes time to start moving along again. If you look at the upper GI, that's a whole different thing, because there's esophageal tears that can turn into esophageal cancer. There's going back to the dental and to the mouth things too. I mean, I can go on and on. It just is, it's a very complicated thing. And unfortunately, these things may take some time, quite a while, to come back. And sometimes people have done irreparable damage to some of these organ systems. Kidneys, again, especially with the use of diuretics, that's a common thing with patients with eating disorders. So that really does affect kidneys. Liver, part of the GI, but when you put the liver, how eating disorders affect the liver, how substance use disorders affect the liver, put them both together, and the poor liver is really having a difficult time functioning. We have people that come in with cirrhosis. We have people that come in with really low, their liver is not functioning. Their lab results are very, very concerning. We had one person come in one time, a young woman, she was in her 20s. Her doctor she had a history of substances, severe eating disorder, and she had been put on hospice. And she was able to get sober. And she said, I'm not ready to die. I want to recover. But in order to do that, she knew she had to stay sober, and she knew she had to work on her eating disorder, because eating disorders really adversely affect the liver also. And the problem with her was her liver function. I mean, fortunately, she did the work. She, she went through all of our levels of care, and she came out and survived and did well, and is doing well. And that was something that was really encouraging to see. The musculoskeletal system. So many people, even young people, have they're having broken bones. They're having vitamin D deficiencies that lead to all types of medical complications. And then again, just a whole host of lab abnormalities, which reflect all the systems that are being affected by the eating disorder. And in addition, you put that into with substances and what that does. So.
We have a question.
Mm-hmm.
How is the thyroid affected? I know several people with eating disorders who then end up being diagnosed with Hashimoto's disease.
Mm-hmm.
Are they connected?
Yes, they are. I mean, I can't say because I'm not their physician, but that is very common. There's something called euthyroid disease. And that's something that is common with eating disorder patients, but we see the same thing, a lot of people with Hashimoto's. And sometimes, then you have just even overall, just the thyroid is not working properly. And again, eating disorder, malnutrition, all of those things affect all of these types of systems. So that's something that we're seeing a lot though more of too, are just other types of thyroid diseases. And people that unfortunately have to be on medications for the rest of their life to manage that. Something else that's interesting too, something I saw with a few of our patients, a couple of my patients a while ago, we have a lot of people that have trauma. That's a very common part of an eating disorder and people with substance use. So these two patients of mine both had serious trauma in addition to substance use and an eating disorder. Because the trauma was long-term and sustained for both of them, particularly one, basically that adrenaline that gets fired off in that fight or flight in those moments where there's a trauma ensuing. Essentially, her body had dumped so much adrenaline, and over time, essentially that whole part of her system stopped working. And so I think what I'm trying to emphasize is that if you even take the other types of psychological, especially trauma though, that can even potentially, there may be some brain injury, there could be a lot of things associated with the trauma, that is going to complicate things even more for somebody who has both of those disorders. So hopefully that makes sense. Okay. All right, so here's some stuff on the connection. Some more stuff on the connection. And it's really like, this is what it is. It's unfortunate whack-a-mole game where, okay, I'm doing well with my eating disorder. I'm not purging, I'm not binging, but unfortunately now I'm using more substances. I'm smoking all the time, smoking marijuana all the time. And then there's this cross addiction maybe with love and sex, with spending. We see a lot of self-harm again and codependency. And so sometimes without getting the whole person, with really, I think the importance of trying to encourage treatment is to get underneath what is driving this. And of course, helping somebody develop the skills of how to function in everyday life in a world that was overwhelming. Because if not, you're gonna see this kind of back and forth. And unfortunately, people can do this for a very long time where they go back and forth, and their whole life becomes just one issue after another. So getting concurrent treatment, working on both issues at the same time is really key. Okay, some of the obvious connections that happen, this is something that we were talking about before, but people use food or the lack of food and substances to help them deal with their emotions by not feeling emotions in a lot of ways. They use an eating disorder and or substance use to deal with recovery. A lot of people come in who, the idea of getting rid of their eating disorder, they're having really bad medical issues, say. They can't, they're really not able to function. They had to quit their job. They're weak all the time. And then they start really working and they're very motivated to work on their eating disorders. But then substances find this way to cope with all of that stress and the triggers that are still there. So that's something that is common in treatment. And here that substance use may be used as an eating disorder to cope or compensate for the lack of the chemical and reinforcement. And as we talk a little bit about the brain, it's really evident to see how similar the brain is affected with an eating disorder and with substance use. And so what people often feel from the use of substances is sometimes the same as the chemical reactions that they're getting from their brain from an eating disorder. Okay, so just a little infographic here. Won't go over it too much, but the one thing that I think is very important to look at is that 50%, of individuals with an eating disorder abused alcohol or some type of illicit drug. And then some other percentages there at the bottom. Again, the percentages and the research is improving. So my belief and expectation is that we're going to see more correlations and more research that shows even stronger correlations between the two, since this is an area that people are really looking at right now in terms of research.
We do have a question.
Mhm.
There's a couple, but I'll just run around.
Sure.
Do you think trauma therapy can resolve an eating disorder in the long run? And then kind of going with that, somebody else asked, do you think IFS has a lot of efficacy with eating disorders?
Yeah, those are good questions. So the first one, I think that the complication of an eating disorder and substance use with trauma is, working on trauma is often a critical piece in order to move somebody in their recovery with either or eating disorders or substance use. But specific to eating disorders, I don't believe, and I've never seen it as like once the trauma is resolved, the eating disorder will, kind of just dissolve. Oftentimes the effects of eating disorder behaviors, trauma, changes to the brain, it becomes, unfortunately, it takes on a whole new use. So not just a way of managing trauma, but that type of the eating disorder and all this different, areas in a psychological way, the way it affects the brain. Sometimes that's hard to, because then you're treating all different types of areas. So for instance, somebody's self-esteem, somebody's depression, other things that may still be prevalent, their own body image is another one. It's critical to work on that trauma in order to really create a meaningful and lasting recovery, absolutely. But I think there will be a time when it's important to know that if somebody's not medically stable with their eating disorder, any type of trauma or even just, psychological treatment may not be effective. So, but yeah, we've, and I've had a patient too where she did really well. She weight restored, she was doing great. She hit a wall. And until we started dealing with that trauma, it was really hard for her to move forward. So, yeah. And then IFS. So IFS is something that's becoming more common with eating disorders and eating disorder treatment too. And I think it can be an incredibly helpful way of understanding and looking at the perspective of eating disorders. So that's internal family systems. And it kind of operates in the same way of schema therapy in a way of my eating disorder self or my other self, and understanding it from that point of view. Again, I think that with eating disorder treatment, it's so important to be able to use so many different types of modalities. IFS is a good one. And I think though, but only using a lot of IFS could also backfire in some ways where people are maybe not taking all the responsibility for their eating disorder. That was my other self. There has to be this incredible integration of understanding, again, what is underneath all of it, what was driving the behavior, and being able to separate that out and look at that through IFS can be very helpful. So hopefully that answers that question. So this is just another new statistic that I don't know how, it actually was from 2019, the research was done. It really just kind of talks about the increase in substance use, misuse of substances and what that's looking like. I can guarantee you that if this research went through 2020, the numbers would be different. With COVID, we know that the number of substance use, people diagnosed with substance use disorders, overdoses, deaths has really substantially increased. So it'll be unfortunate, to see how COVID has affected people with substance use disorders. And again, another statistic here. The reason why I incorporated this one is that it talks about people seeking treatment. So for the amount of people that have a diagnosable substance use disorder, the amount of people that are actually getting treatment is still quite low. And you can see that there's disparities between age groups and ethnicity, which is an issue that for those of us in healthcare and you all who are treating people, really being aware of how there's so many people out there and what we can do in order to get more people coverage, making sure they have insurance coverage to pay for their treatment, how important that piece is. And then, the idea of thinking about with all these people, the reality is that there's probably 50% of these people have some sort of eating disorder. Okay. So this is what happens, and we see, I think at this point, there's no drug we haven't seen that is used with people with eating disorders that have benefited somebody with an eating disorder in some way. Sometimes it starts with caffeine, smoking, of course, alcohol, cocaine, meth, marijuana, heroin, and opiates. And people don't oftentimes, well, at least for quite a while, the idea of heroin and opiates wasn't one of the drugs or two types of the drugs that were on people's radar. And that's true. But what opiates do with somebody with an eating disorder, one, it can dull any type of hunger. It can also dull satiety. So, but it also is another way of just completely distracting and shutting off and disconnecting from the eating disorder thoughts, the rumination that happens in our, in our minds with people with eating disorders. It's just this constant thinking about food, ruminating on it, thinking about what I ate, thinking about the calories. Heroin and opiates can really stop that process quite a bit. And again, we have that good example of people saying that I need marijuana in order to eat. Cocaine and meth. Meth is the most commonly used drug. It seems like one of the most commonly used drugs with eating disorders because it really does stop hunger and increase metabolism and can create a whole lot of problems, especially from a cardiac standpoint. You get this increased heart rate for somebody who's malnourished, and it's instant, potentially instant death. Sometimes what we've seen though is people start, I have patients a lot of times that never were into any type of illicit drugs until they started struggling with bulimia or their eating disorder and started using laxatives and diuretics. That and diet pills, that was a way, just getting used to having some sort of external or some sort of medication that they were using in order to facilitate their eating disorder, parlayed into a use of illicit drugs. And that is sometimes kind of the gateway. Okay, so I know we're getting, what time were you done?
About 20 minutes left.
We have about 20 minutes left. Okay, so I'm gonna go through these 3 case examples of people that were my patients, and then I'll refer to them too as we go forward through the presentation. So my first one is, her name is Donna, that's not her real name. She came in 23 with anorexia and alcohol abuse, and she had been to treatment 3 times, and each time she would not acknowledge that alcohol was a problem. And the reason why she came 3 times was at each point she would do well with her eating disorder, and then she would go through different levels of care, but she really wasn't willing to look at the alcohol. And no matter what I said, no matter how much awareness I tried to give her an education, she just could not accept that. She ended up getting very sick. She ended up needing heart surgery. Her mother called me the day she was getting taken to the emergency room, needing heart surgery. She had like a pleural effusion, actually something a little bit more complicated than that, where the walls of the heart, all of these things were not functioning. Very, very dangerous. And at the time, and a lot of doctors still, they didn't make the connection. And I told her mother, this is I don't want to say a direct result, but this is in connection or potentially as a result of her eating disorder and her alcohol use. It then came out, there's been a lot more subsequent research since connecting the two things also. But she could not at all. She was not able to stay in any kind of recovery from her eating disorder until she was sober. She felt like, I'm gonna be okay. I'm on my meal plan, I'm doing really well. And then all of a sudden she's drinking. And I would say it's like this window, so Donna, it's a window. When you open the window to one disorder, you can't control how fast it's going to, open, how much more it's going to open up and let all the other behaviors in. And, until she was able to figure that out, she couldn't have any type of real recovery. Second one was the gal who came here. She had been in substance use treatment, had a very bad, a lot of cocaine use, really bad self-harm, and a lot of drinking. And she was very, very scared of gaining weight. She used cocaine to really reduce her appetite, increase metabolism, all those types of things. But when she started to, when she got sober, her eating disorder and self-harm, especially, out of control. She ended up taking a knife, cutting into her abdomen, trying to get what she was saying fat out, ended up in the hospital, very bad infection. But it was just really amazing how quickly it happened, where she finally got she finally got sober, but her eating disorder behaviors became incredibly dangerous. And then the last example is somebody named Kathy, and she was 34. She had bulimia, and she was always a social drinker. She did not ever, in her, based on history, based on, reports from family, husband, alcohol was never a part or a problem. There was social drinking, that type of thing, but there hit a point in her treatment when she was an outpatient where she was having like a glass of wine with her husband here and there while she was doing outpatient treatment. And she started feeling this sense of, wow, that kind of just numbed me and emotionally helped me detach in a way that I haven't felt since I was using my bulimic behaviors. And I explained the need to stay sober. I really said, it's going to be very hard to really get to what is going on unless you're sober, because that is something, even just that amount of, well, I'm looking forward to a drink, I'm going to have a drink for dinner. It's another way of disconnection. So fortunately, she was able to do that, and she was able to successfully get through treatment and be successful. She is still a social drinker, but that's it. She's not drinking abnormally. As her eating disorder recovery improved and increased, she was able to incorporate social drinking back in without it becoming an issue. Okay. So some of the common links. So the brain is a huge part, and there's quite a few, I think there's a few slides on the brain, so I don't want to get too far into it, but I think what the highlights are and the things to really emphasize is that the reward pathway of the brain, the limbic system, those types of things, what eating disorder behaviors do mimics what substances do in the brain. So to the next slide. So here's a couple examples, a couple pictures here. So there's been so much research on understanding the frontal lobe, all of these things like the feeling side, the parts of the brain that give us judgment and planning and all of those things, which are clearly lacking in people with eating disorders and substance use disorders. But what they also have been finding, and I think which is really interesting, is on the picture about the insula, is that there's more involved there in terms of hunger and satiety, different types of emotional feelings that are really involved with eating disorder behaviors. And there's been more research too, looking at the hippocampus and how the memory, the holding of the memory, and that just ritual part becomes a big deal for somebody and triggering somebody who's trying to find some sort of semblance of recovery. The important thing is that the things that we see, the images that have been done for people with eating disorders and people with substance abuse, which I'm sure you guys have seen, people will see a drug, they'll see somebody in the middle of a ritual, and their reward system and all of that adrenaline and all of that dopamine starts to fire. Not because they used a drug, but because they even saw and looked at that whole point of the ritual. The same thing's happening for people with eating disorders. So when they're doing similar studies, they're finding the same reaction. And when you consider that ongoing depletion and almost addiction of what that reward system is giving the body, then once somebody is depleted, depression, anxiety, and then of course this feeling of needing to get more. So this goes a little bit more into the specifics of the insula. It's one thing that I found interesting in the study, in researching this, is that not only do the eating disorder behaviors and substance use, are affecting the things that we already knew about in terms of frontal lobe judgment, that feeling of getting that dopamine released, but they're finding that the brain, that part of the brain, is hyperactive. And what they did see too was that it stayed that way for a period of time. And that even after the drug or the eating disorder behavior was taken away, that part of the brain was still remaining to be hyperactive. Okay. So another big part of this, kind of going back to when I was talking about my patient who had a lot of trauma. So the state of fear and stress and the amygdala firing all the time, it just floods the body with the stress hormone, with cortisol. And the lack of cortisol, or the large amount of cortisol can affect and create different disease systems in the body. And that is something that is happening a lot, unfortunately, with people with eating disorders and trauma and substance use and trauma. So it's that feeling of, okay, what happens when you're in the middle of that feeling of trauma and the fight or flight or the freeze? And based on whatever path or however one reacts, the brain is incredibly affected. And the reason why this is important in treatment is to understand too that how those response systems, how somebody responded to those triggers, to those cues, really has a lot to do with what they did in order to manage the feelings, that flood of adrenaline, that flood of cortisol, what that feels like in the body, the anxiety of the flight of that, what happens when somebody feels like they have to run, they're in this incredible fear. Those feelings, those emotions will many times in some of our patients' mind need some sort of self-medication to manage those response systems. I hope that made sense. So personality links, there's a lot, very much the same that you'll see with both disorders. Poor emotion regulation, a big one. Having a very hard time being rational, being able to manage emotions, like this excessive emotions. A lot of sensitivity, being impulsive. Interesting, the studies that are being done about really linking connections of eating disorder diagnoses to specific substance use disorders. There's a lot of research there. Bulimia strongly correlates with substance use, especially with drugs like cocaine and meth, that impulsivity that is common for both of those two disorders. And then there's risk factors, these things that will put somebody in a situation where they are more likely, especially with ongoing issues, that they are going to be more prone to getting an eating disorder or substance use. I think finding in research that it wasn't just people who already had a diagnosis of substance use and an eating disorder. What was interesting and what was really important to see was that people who had never had a substance use disorder ever in their life, and even didn't necessarily have, they didn't have a genetic component, they didn't have any type of, other association with members of family that weren't, like mother, father, brother, sister, those people are still, regardless, almost 50% more likely to develop a substance use disorder. So we have people that will come in and say, I've never used substances. It's never been an issue for me. I don't have a problem with it. You know, leave me alone. It's really critical that we are educating these people and letting them know that just simply by the fact that you have an eating disorder, your brain, your body, you're wired to potentially fall into certain behaviors or, you know, certain situations where drugs and alcohol could become a very dangerous thing. So it's important that, and it's the same thing for people with substance use. A lot of people with substances, you know, like, well, I've gained weight, or, you know, I can't eat. And those types of things then can easily become an eating disorder, a diagnosable eating disorder. All right, so then in treatment. So what do we have to do? This is just some really overall types of ideas. You know, abstinence, of course, the medical stuff is really important. Containing all behaviors, and medications. Some medications are so incredibly helpful for our population that in many times it can be the make or break in some ways. That rumination I was talking about, that mind just going and going and going, is something that's very detrimental and difficult for people to move through into recovery. Dietary approach, making sure that people are getting you know, proper meal plans that include, you know, not good foods, not bad foods. It's all foods in balance, variety, and moderation. And also looking at not really being careful to fall into you're too underweight or you're overweight, and taking a look at how to approach people's body shapes that is not creating more guilt, shame, or anything like that.
Great question. What are anti-craving meds?
So anti-craving meds can be, it can be like naltrexone, and also, I'm totally blanking on some of the others, but naltrexone, for instance, is a common one used for people that have opiate addiction. It reduces the cravings, but they're also finding that naltrexone can be helpful in some people with binge eating disorder. So whether the medication helps reduce the craving for alcohol or some sort of drug, that can be helpful in the process of recovery. I hope that.
Yeah.
Okay. All right. So then physical activity is important, but again, for people with eating disorders, it can be, we have people that are exercise avoidant and people that over-exercise. So it's managing and monitoring the physical activity. And then this part, of course, you know, how do we treat people with this cognitive emotional treatment? Getting people to have better skills, being able to have skills, but really involving the use of values. Like, what is really, like, what for you, what's important? What is meaningful? What brings you joy? Some people may say, I have no idea. And then little by little, that may change. But when we can get to this idea of helping people get underneath all of those behaviors to who they truly are, is going to help have, you know, create this identity that is not associated with an eating disorder or substance use. And all these other things are very, very important in that process. But again, it's like with denial, fear, honesty, surrender, these are the same things that people with drug use and eating disorder struggle with. And then spiritual mindfulness, part of the treatment. And again, you know, even with all these complications, the idea of full recovery is possible. And there's hope, because I've seen fortunately a lot of people who have been able to deal with both of these things and come out the other side and recover. And so I know we're pretty low on time, but
We actually have a really good question.
Sure.
So thank you. I have a question. What role does the motivation play in recovery, and how can we address motivation to recover in eating disorders?
That's a really good question. So if you look at APA guidelines, motivation is actually part of the APA guidelines. And what it says for inpatient, residential, PHP, and even IOP is that there is going to be a lack of motivation. That's tough, and that's something that everybody tries to deal with. I think sometimes you have to have external motivators to, you know, eventually create internal motivation. But I also think there's a level of acceptance that people may not be motivated. What I tell a lot of my patients is, at some point it will kick in. If you just do what you need to do, that motivation will kick in. But I think having people in support groups, people outside with encouragement, kind of getting to something that does have meaning or does create some sort of motivation for recovery is important. And motivational interviewing techniques, all of those things are helpful.
Okay. And then we have a question on your thoughts on intermittent fasting.
Yeah, that unfortunately is a big part of, it depends whether it's intermittent fasting in terms of some sort of detox or cleanse, or, an intermittent fasting is a part of eating disorder also. Actually, that can be part of a compensatory behavior for bulimia, is people that fast and then end up potentially going into a binge purge cycle. But things that have those types of hard line, this is a cleanse, you need to fast, those can be very dangerous, not just for the physical body of somebody with an eating disorder, but for the mind. And why is it okay if they can fast? Or even from religious and cultural standpoints, it's being able to get to sometimes see that what's important is consistent nutrition. So hopefully that answers. Are there any other questions?
What intervention can we apply in developing countries? Some of these people don't have access to medical treatment.
And some of these people are also food insecure too, which is an issue in itself, with people not knowing and understanding when they are going to be getting food, and developing that feeling of so much malnutrition and so much starvation. I know that overall the eating disorder world and eating disorder world education has really expanded. Part of the residential eating disorder consortium group that Emily mentioned, there's so much work that we do even with international organizations that are working on eating disorder, but it's about getting care, just overall care, to people that are in places that don't have that type of accessibility. There's still so many parts of our world, so many countries where people are still starving and food insecure. But what we've seen, and interesting at Montecatini, we've had people come from countries where they couldn't and didn't have weren't getting consistently fed, and how that's affected their overall life. But again, I'm encouraged by more and more organizations who are really trying to approach and help those in need.
For everybody asking about the CEs, you will get an email from a company called R. Cassidy within 2 to 3 business days, so probably early next week. And if you have questions on that, I'll put my email in the chat box and you can reach out to me. But I have everybody's information. If you registered on November, I have all of your info, so you're good to go. You'll just get an email from R. Cassidy. I'll put my email on there right now.
Okay, no, we're getting close to time. Are there any other questions?
There's one more question.
Okay.
Well, there were some questions about ARFID. Could you explain the difference between ARFID and sensory processing differences in neurodivergent people, so like autistic?
Right.
ADHD?
So oftentimes ARFID is very common in people with that type of, that diagnosis. And I think that you'll see different degrees with ARFID patients where it's definitely, you can really distinguish the difference between somebody who has ARFID and say maybe anorexia. But especially people that have other diagnoses that affect or their senses in general, it becomes very difficult, because when you have somebody who tastes something differently, smells something in a more exaggerated way, has that distortion, it's hard. It's a different type of treatment in many ways, because they're not dealing with the feeling of the shape and the weight of their body and how they look. It's more of really that taste and that feeling, you know, of how their senses are affected. So I don't know if I'm really answering the question, but what's really important is still, it's kind of a lot of exposure and a lot of sensitive work of slowly starting to incorporate different types of food, feeling what that feels like when somebody eats something where the texture is really disruptive, and then processing the emotions that are going on, or people that have an altered sense of smell or taste, and being able to either, you know, find foods that are more palatable, I guess, in a sense, but also helping people. What's really effective is really processing the emotional and thoughts that are going along with what's happening when that person is experiencing that food. I hope that.
Yeah, we have a couple more questions. If anybody needs to jump off, they can, but I think Sharon can stay on and answer a couple more questions. Given the team approach necessary to foster eating disorder patients' recovery, how is this being fostered in the age of telehealth?
That's been a very big challenge and a really good question. So people have, because they've been so reliant on telehealth, what we've seen is people are incorporating all these different types of this multidisciplinary team. They have a dietitian, they have a therapist, a psychiatrist. What I think can be very tricky with the virtual and all the telehealth is that for somebody that needs consistent medical or, you know, some sort of medical monitoring, needing to get a weight, needing to get labs, all of those things are critical. That's critical medical need. So if you have somebody that is receiving a lot of telehealth support, there needs to be at least somebody, in my opinion, that can get eyes on that person, be able to look at some sort of tangible data of what's going on with that person, weight, vitals, labs. It's challenging, but it's very easy for people to hide behind that camera and say, I'm doing okay, things are well. And the reality is there's more internally going on. So,
Okay, there was another question, sorry, I just lost it. How do we approach the media influence about body acceptance when people are at a healthy or unhealthy weight?
Yeah, that's a great point. So that has been, I can't remember if I even had a slide, if I mentioned it. There may have been one in there. I'm talking about the media influence and especially how that's affecting people that are younger now and younger, especially with social media and being able to, you know, we have, there's so many sites about being thin and these really scary sites of how do people competing about who can be sicker, who has a tube for nutrition. I lost more weight. It's really scary of how all this has just amplified the disorder. There's some big movements. One of them I just quickly referenced was Health at Every Size. That movement, in addition to the body positivity message, that has actually been working and helping infiltrate some of the media. I think you can see, like, even in Target, there's you know, things are different. The way that sometimes the first section of people that you walk into, or you see people that with normal body types. Same things in commercials, people with normal body types. So organizations that are really working at encouraging body positivity, and there's, you know, some great people, those are the things that are helping. And actually they've helped to the point where there's been a noticeable difference in some parts of the media. And also, you know, just different steps that different corporations have taken in order to make sure that they don't have somebody who's severely underweight and anorexic who's representing their product.
All right, one last question. Could you please discuss your approach to the psychotherapeutic work you and your residents collaborate in?
So the psychotherapeutic approach, it will vary really, especially between levels of care. At residential, oftentimes there's, depending on how medically unstable or how malnourished a person is, the approach has to be different, because some of the work is not even, you're not even really able to do at times with people that are in the residential level of care. But the approach, especially with substance abuse, is part of that, is looking at going back to, so all of those things that I mentioned at the end, is addressing the physical and medical, yes, the cognitive and emotion, and the spiritual, and of course the dietary. But with us, you know, our therapists will work and do different types of, you know, we do DBT and CBT for skill building. But in order to get to the stuff that's underneath, they're maybe doing some IFS, or they may be doing some types of attachment work. We do a lot of attachment work. That's a big part of these two disorders, and understanding the eating disorder substance use through the lens of attachment, which has been something that's very effective and powerful. And then, you know, really doing family therapy is also key. And even if it's not a family, it's looking at the system that's in a person's life and how that person is participating in the system. And in the system is the substance, and in the system is the eating disorder, and addressing it from that process view, and the systemic issues that are evolving and happening as a result of the disorder. So it really is a variation. And what's nice about our program too is that we really do individualized treatment. So in some case, you may see somebody who needs some more work on trauma. And maybe when they're in a lower level of care, we can start incorporating different somatic work or even EMDR. So there's